interesting as our previous session as well. So I'd like to introduce our, so we've got some panelists and then we've got speakers as well. First, I'll request the panelists who are physically here to be with us on the stage, please. So we've got Dr. Kamran Rashid from Rashid Cancer Clinic in Rawalpindi. We've got Dr. Musawir Bangish, who's a consultant oncologist here at CMH. And then we've got Dr. Rija Tariq, who's a consultant clinical hematologist at Anmol Hospital, Lahore. We'll be having Dr. Jasmine Zain, who's a professor at City of Hope, Duarte, USA. And she'll be joining us at online. She's a director of T-cell lymphoma program there. So our first talk is going to be from Dr. Tanya Siddiqi. So Dr. Tanya Siddiqi is the director of CLL program, which is the chronic lymphocytic leukemia program, and associate professor at City of Hope, Duarte, California, USA. Over to Dr. Tanya Siddiqi.
Assalamu alaikum. My name is Tanya Siddiqi. I'm a hematologist at City of Hope in Southern California, and I specialize in lymphomas and CLL. These are my disclosures. I'll be talking about how I treat CLL in this day and age, and it has become a fairly big topic to talk about, so I've broken it down into frontline management and relapse setting management with some of the newer data to talk about. Let's start with the frontline setting. So we already know over the last several years that starting with ibrutinib, the first generation BTK inhibitor, oral targeted therapy that was developed and approved for CLL, that this particular therapeutic agent and everything else that followed seems to be better for CLL patients in the frontline setting than the historic chemoimmunotherapy. So much so that we've started seeing overall survival advantages and are now studying combinations of these novel therapies to see if we can do better and better for our CLL patients. Just this year, we saw Dr. Paulo Guia's data published on how Imbruvica or ibrutinib seems to improve CLL life expectancy such that when they pooled ibrutinib-treated patient information from multiple randomized large trials and compared it against age-matched general population, they don't see a difference anymore in life expectancy. Whereas in the past, which is the lower curve on the right, in the past, the previously used chemoimmunotherapy regimens really seemed to shorten people's lives, or at least they did not improve CLL life expectancy per se. We now know that acalabrutinib confers a very favorable response in CLL patients and may have even less side effects, especially where atrial fibrillation and cardiac side effects are concerned, things like sudden death, etc., with a great improvement in PFS and OS noted on the Elevate-TN trial. Now 6-year and counting follow-up has been shown. Similarly, the Sequoia trial, with a little bit shorter follow-up than acalabrutinib so far, does show that zanubrutinib patients do much better than chemoimmunotherapy patients in terms of progression-free survival, at least. And we continue to follow these patients over time to see if there's any overall survival advantage as well in the future. CLL14 trial gave us an excellent frontline treatment options, which was fixed duration of venetoclax plus obinutuzumab, and now we've been following this data for 6 to 7 years already, 6 years at least. And you can see in the blue line of the figures that the progression-free survival for venetoclax plus obinutuzumab was much better than chlorambucil plus obinutuzumab. And on the right side, you can see that the curves are starting to separate. So it'll be interesting to see if an overall survival advantage is also shown fairly soon. Additionally, ven plus obin confers really good progression-free survival even in patients with TP53 mutation or unmutated IGHV status, the poorest features of CLL. Their progression-free survival can be as high as 4.5 years or even 5+ years in certain situations. And for patients who truly desire a fixed duration therapy, I don't let porous features hold me back from using this combination. The Gaia CLL13 trial by the German CLL study group has shown that venetoclax plus obinutuzumab really seems to do better than venetoclax plus rituximab in terms of progression-free survival. And adding ibrutinib to that doublet, venetoclax plus obinutuzumab combination, does not seem to add that much to the progression-free survival at all, and might in fact add more to the toxicity. So I think in this particular trial, comparing many different treatments, including chemotherapy comparison, venetoclax plus obinutuzumab wins out big time. So the Captivate trial has been updated recently, and especially the fixed duration cohort here. And this is a study of fixed duration in ibrutinib plus venetoclax therapy for 1 year. And you can see on the right side that the progression-free survival curve seems to sort of continue to do well in various risk categories of CLL and overall as well. So the PFS rates seem to be fairly durable and high, even with the 5-year follow-up after finishing 1 year of I plus V combination therapy. And we know that with the GLOW trial, the I plus V combination compared against chlorambucil plus obinutuzumab in older patients or patients who are frailer seems to have led to EMA approval in Europe for I plus V as a frontline treatment option. However, given the toxicities and some amount of sudden deaths noted in the ibrutinib-containing arm, has led the FDA to not really approve it in the US yet because, unfortunately, ibrutinib has fallen a little bit out of favor because of his cardiac and arrhythmia type side effects. But you can see here that I plus V really did much better in terms of progression-free survival, and even the OS curves are starting to separate. So if I plus V is good, then what about I plus V plus obinutuzumab? The triple drug combination was tried in the Alliance trial and compared against ibrutinib plus obinutuzumab, and does not seem to show any major difference in terms of efficacy. There might be more infections in that group potentially. There are other trials which are studying the triple combination using a different BTK inhibitor, and we'll see how those go. But at this point, it does not appear to me that obinutuzumab is absolutely necessary if you're using the oral doublet combination therapy. The Bowen study is a phase 2 trial of zanubrutinib plus venetoclax plus obinutuzumab, and you can see that the progression-free survival curve on the right looks excellent, and also there are very high minimal residual disease rates in these patients, and they seem to last for a long time in terms of maintaining their MRD-free survival. So here's an algorithm of what I like to do for my frontline patients. If there is an indication for treatment and they have TP53 mutation or deletion 17p, I do try to offer continuous acalabrutinib or zanubrutinib therapy, which is preferred over fixed duration treatment in most situations. If they don't have TP53 mutation, but they do have IGHV unmutated status, then again, I try to stick with continuous acalabrutinib plus minus obinutuzumab or continuous zanubrutinib therapy. However, if there's mutated IGHV, then I definitely do try to prescribe fixed duration ven-obin, provided they have good kidney function, etc. And what about the BTKI plus BCL2I doublet therapy in the US at least. Well, we will be hearing about the Amplify phase 3 trial, first data presentation at ASH this year. It's really a trial of acala plus ven compared against acala ven obin versus FCR or BR chemoimmunotherapy. I think the trials that I'm more interested in that might be upcoming in the next few years are the MAGIC and Celestial trials. These are truly comparing a BTKI plus BCL2I oral doublet combination against our standard ven-obin fixed duration therapy. And I think these trials will help us really decide which treatment regimen will really be the best for our frontline patients. So let's talk about the second line setting now. I usually like to see what patients received in their frontline setting and then decide like what would be the best for their first relapse. The Murano trial really has given us a very good option with venetoclax plus rituximab, which seems to have a very long and durable remission in terms of progression-free survival after 2 years of fixed duration treatment. The Ascend trial does have acalabrutinib as a continuous therapy, and that seems to have done much, much better than bendamustine rituximab or idelalisib rituximab as well. And we know that acala or zanu, while might be similar in efficacy to ibrutinib, definitely have less atrial fibrillation type and sudden cardiac death type side effects compared to ibrutinib, so they are favored over the original ibrutinib BTK inhibitor therapy, and in fact, zanubrutinib might even have a slight progression-free survival advantage over ibrutinib. So in the second line setting, as I said before, I like to see what they used in the first line treatment and then decide if it's been more than 5 years, maybe you can reuse the same treatment again. But I generally like to change the mechanism of action in the second line setting. So if they started with a BTKI, I try to go to ven. If they started with ven, I try to go to a BTKI. And there are, multiple options, thankfully, for patients because retreatment also works oftentimes, especially if there's no known mutation in the BTK pathway or even the venetoclax pathway. The real new or novel data that's upcoming or has been worked on lately in CLL has been in the third line and beyond setting. We now have the non-covalent BTK inhibitor pirtobrutinib FDA approved in the US for patients who have failed both covalent BTK inhibitor therapy as well as venetoclax. And this was based on the Bruin phase 1/2 trial, which is a large trial of patients with relapsed refractory CLL who had prior BTK inhibitor therapy, essentially. And you can see that patients responded to Pirto if they'd had prior venetoclax, if they had the BTKC481S mutation, or if they had never had venetoclax, et cetera, before either. This data was updated by Dr. Jennifer Woyak at ASH last year, and after 30-month follow-up, you can see that the BCL2 naive patients did actually better with pirtobrutinib than the BCL2 exposed patients, but really the need is highest in the BCL2 exposed patients as well. And of course, everybody had prior covalent BTK inhibitor therapy. And then CAR T-cell therapy has also been FDA approved in the US for relapsed refractory CLL after having tried BTK inhibitor therapy as well as venetoclax or BCL2 inhibitor therapy. And I updated these results at ASH last year. Basically, the primary endpoint of complete remission rate was 20% and was much higher than the originally thought 5%. The overall response rate was 44%, and the undetectable minimal residual disease rate was 64% in these double refractory patients, if you will. Patients had a median of at least 5 prior lines of therapy, so they were very heavily pretreated patients. The safety profile is shown here. So no grade 4 or 5 cytokine release syndrome events. There were about 8% grade 3 cytokine release syndrome events on this trial with the lysocell CAR T cell. And then as far as neurotoxicity is concerned, there was 1 grade 4, no grade 5s, and about 18% grade 3 neurotoxicity events, which are managed with dexamethasone and other agents. So in the third line and beyond setting, I like to basically use pirtobrutinib for salvage, presuming patients have had both covalent and BTK inhibitors as well as BCL2 inhibitors previously. And then I try to get them to CAR T cells while they're sort of under control with pirtobrutinib, because if they kind of start progressing rapidly again, it's hard to get them to CAR T cells in that situation. If they've never had BCL2 inhibitor before or a covalent BTK inhibitor before, then of course you need to try that. Let's say it's somebody who had chemoimmunotherapy, went on to get venetoclax, never had a covalent BTK inhibitor. I would definitely try that first, of course. I'll talk about a couple of novel agents under clinical trial investigation currently in the relapsed refractory CLL setting. So one is the BTK degrader NX-5948. BTK degraders are basically agents that use the ubiquitin proteasome pathway to degrade the BTK enzyme. And by this mechanism, they can overcome treatment-emergent resistance mutations in BTK. It's an oral therapy, much like BTK inhibitors, and is being studied in multiple doses, currently on a phase 1 trial. Different dose levels are being studied in this first-in-human dose escalation study, and patients need to have failed at least 2 or more prior lines of therapy to be eligible for this study. We are trying to establish the safety and tolerability of this agent, as well as establish the recommended phase 2 dose. And it's generally very well tolerated. The side effects seem to be fairly similar to BTK inhibitors in general, some sort of bruising, purpura, a little bit of cytopenias on occasion, fatigue, some headache in some patients, rare hypertension potentially. There has been one DLT thus far, and a couple of patients stopped the drug, but not in the CLL cohorts. And I'll have to say that the biggest, most striking feature thus far has been, I think, that no atrial fibrillation has been seen thus far, but of course follow-up is short and we need to see how people do with longer follow-up. You can see that the waterfall plot shows a lot of shrinkage of the burden of disease with this agent. A lot of partial remissions were noted, have been noted thus far. Secondly, I'd like to talk about subcutaneous epcoritamab, which is a CD3 and CD20 bispecific antibody, and it's given subcutaneously to patients in the schedule that's shown there in that first green box on the left. There were 23 patients on the expansion arm. Among the 23 patients, majority of patients had poor risk features of their disease. Median prior lines of therapy were 4. Everybody had prior BTK inhibitor therapy, of course, but then 83% had also had prior BCL2 inhibitor therapy, and 1 patient had prior CAR T cell therapy as well. You can see that in the evaluable 21 patients, the overall response rate was a fairly respectable 62% with a complete remission rate of 33%. And in addition, the patients who had poor risk features of their disease, like TP53 mutation, double exposure to BTKI and BCL2 inhibitor therapy, as well as IGHV unmutated status, all seem to have very similar ORR and CRR in this study thus far. The depth and duration of response with this continuous therapy at this time seems to be very encouraging as well. So most patients achieved an undetectable minimal residual disease to a level of 10 to the minus 4, including all the CR patients. And you can see on the swimmer's plot that there are many patients who had ongoing responses for the better part of a year at least. Of course, further follow-up is pending. The main thing to know about bispecific antibodies, especially in CLL, is that they seem to cause recurrent cytokine release syndrome with multiple doses. So you know that in the first cycle, we ramp up the dosing each week, and the main full dose, the first full dose, is given at cycle 1, day 15. And you can see that the amount of CRS events was the highest, of course, and the most severe at that cycle 1, day 15 time point. Steroids are used quite heavily in these trials to kind of mitigate CRS events, but despite that, there are ongoing up to 25% patients who have CRS low grade, however, in the second and third cycles and beyond as well. So that's something that we need to kind of know how to manage and figure out. ICANS or neurotoxicity is extremely rare compared to what we see in CAR T cells, however. And so in conclusion, I think just to know that there's been an explosion of novel therapies over the years in CLL. We've changed our paradigm of treatment altogether in CLL. We don't use chemoimmunotherapy anymore, at least in the US. There's still a lot of novel drugs that are coming through the pipeline, and combination studies are hopefully going to get us to a cure one day. Thank you very much, and I really appreciate being invited to come and speak at this wonderful conference. Thank you very much.
Thank you, Dr. Tanya, for a very elaborative talk on CLL in the context of treatment sequencing. Our next speaker is Dr. Farrukh Awan. He is a professor of medicine at Southwestern Medical Center, Dallas, USA, in the Division of Hematology, Oncology, and BMT. His expertise is in lymphoma, CAR T cells. Over to Dr. Farrukh Awan.
Hello, I'm Farrukh Awan. I work at UT Southwestern in Dallas, Texas, and I take care of patients with lymphomas here. I am very happy to be with you today, and I would like to thank the organizing committee for giving me the opportunity to present today. The topic of our discussion today is how I sequence treatment in patients with aggressive B-cell lymphomas, specifically with regards to treatment of patients with large cell lymphomas and Burkitt lymphomas. It's a complicated topic, and I also realize that there's another presentation later in the program that will specifically talk about patients with relapsed refractory disease. So I will try not to have too much overlap between this talk and the other talks. I'll focus primarily on frontline therapy, and we'll briefly touch on the management of patients with relapsed disease. So this is hopefully enough content for the next 15-20 minutes. So these are my disclosures. So the objectives are, first, we'll start off by talking about large cell lymphomas, and then we will briefly discuss Burkitt lymphoma. That's not a very common thing that we deal with on a regular basis in the lymphoma world. So as you all know, large cell lymphoma is the most common lymphoma in the non-Hodgkin lymphoma world. And the other aggressive B-cell phenotypes are the primary mediastinal lymphomas, again, not very common, and Burkitt lymphoma is another one. These are the three more aggressive types of B-cell lymphomas. Obviously, on the T-cell lymphoma space, we do see AITL and PTCL and so on. But essentially, large cell lymphoma, Burkitt, and primary mediastinal are the three of the more aggressive B-cell lymphomas that we take care of in our practice. So I've shown this case before, but I'll just give you guys an update if some of you has seen this before. But this is a 22-year-old patient that we're actively managing right now. Initially presented a while ago. Details are kind of mixed, but this is the best I have. He was diagnosed just by some coughing and feeling some malaise. Wasn't very symptomatic as such. A young guy, otherwise in perfectly reasonable health, working. So he was found to have a large mass in the chest, and there was biopsied and was found to be large cell lymphoma. Because of his initial presentation, the bulky disease, he was started on treatment with EPOC. Initially, the treatment wasn't very effective. His interim scan did not show significant improvement. So it was stable disease at the cycle 3 scan, and then at cycle 5, he had florid clinical progression of disease. So after 5 cycles of treatment with our EPOC, his therapy was discontinued and he was switched to gemcitabine with carboplatin. So I don't have all his initial scans, but after his gem carbodex, this was his scan. And you don't have to be a radiologist to figure out that this is a pretty dramatic case. I mean, the patient had disease all over, extensive liver involvement, significant bulky disease in the chest area, which was causing a lot of coughing and discomfort. So anyway, this is a primary refractory large cell lymphoma, otherwise a healthy patient. So this person undergoes CAR T cell therapy with Axicell. Again, did not touch it. He had stable disease at the completion of CAR T cell therapy. He was then started on bispecific antibody epcoritamab. He had no problems with that. Tolerability was fine, but he didn't have a response. He had stable disease. And then he was referred to me at that point. So I put him on a clinical trial that I had. His scan hadn't changed, by the way. It was still the same scan, extensive disease everywhere. We had a clinical trial available with a BCL2 oligonucleotide, and then that's what we gave him. Didn't really do much, maybe slight improvement, but otherwise this was his scan after his clinical trial. So this is the scan that I did after his 5th line of therapy when he came to me. So by now, the guy was cytopenic. He all 3 lines were pretty much nothing. His platelets were 20, 30,000. His white count was low. His hemoglobin was low. He was transfusion dependent and symptomatic and getting weaker and weaker, even for a 22-year-old person, 23-year-old person at that point. The therapy was taking its toll. So this person was almost close to being on hospice. And the last discussion that I had was, I'll give you a cycle of polatuzumab because that's the only thing left. I gave him polatuzumab with rituximab for 2 cycles. And then his coughing improved, his counts improved. That was encouraging. So I figured I will add ice to it because he hadn't had chemo for 6 months by now. So I gave him 1 cycle of rice along with the polatuzumab. And this was his interim scan. So dramatic improvement. His chest lesions went away. He still had some supraclavicular lymphadenopathy, but overall he had a phenomenal response. I gave him another 2 doses of polatuzumab with rice, got his allo transplant figured out, and then took him to an allo transplant with TMLI conditioning. This was his pre-transplant scan, and he now is 6 months out of his transplant. He has some grade 1 GVHD, but he is in a complete remission with MRD negative disease. So this was a success story. This is kind of tells you how I'm thinking about this case and how I manage this patient with really bad disease. And is there a standard here? There really isn't a standard if somebody is failing CAR T or transplant, autologous transplant at least, in chemosensitive disease. So everything that you have, clinical trials, whatever you have, this was one of the ways we felt it was appropriate to treat this patient. So with that, let's focus on patients with advanced stage disease first in the frontline setting. So what do we do nowadays? So the big question in the field is whether polatuzumab with R-CHP should be the standard of care in patients with previously untreated large cell lymphoma with advanced stage disease. You all are very familiar with the POLARIX study, which compared head-to-head PR-CHP with R-CHOP. And again, standard design, 6 cycles of either chemotherapy followed by 2 of rituximab add-on, fairly standard endpoints, progression-free survival, which did show an improvement of PFS with polatuzumab, rituximab across the board. So basically, a 6 to 7% improvement in PFS. There is recent update at ASH, which shows that this PFS advantage is maintained. So it's encouraging. Now, if you're a purist, you would want to see the overall survival advantage, and that's what we see there. There isn't any right now, and it's hard to demonstrate an overall survival advantage in the current era when you do have access to CAR T cell in most areas of the world, in the Western European areas and in the US, where a lot of the patients participated in this trial. So it would be very hard to demonstrate improvement in outcomes for these patients. So in terms of overall survival, but it's a good start. Prior to that, we didn't have anything that showed us an improvement in progression-free survival when comparing to R-CHOP. All right, so if you want to look at which subsets benefited the most from polatuzumab R-CHP, so across the board, if you go down the line, and this is subset analysis post hoc. So that's why the studies are not necessarily designed to address some of these questions, but generally the trend is towards improving outcomes in patients with large cell lymphoma across all subgroups, especially the one with the non-GCB type, and that's probably the one that I would definitely consider this if you were to argue against the use of polatuzumab because of whatever reason, access, availability, cost, and so on. But I feel that for the most part, Pola R-CHP should be the standard of care for most patients, and R-CHOP may be in the unique circumstance when that's not a possibility. What about other options? Can we escalate our EPOC and dose intensify? That has been done. EPOC for the longest time has been used, and it's been used successfully. And then 50303 essentially showed that there was no significant improvement in progression-free or overall survival with the use of EPOC, and as a result, EPOC is not used as a standard of care for patients with large cell lymphoma, except for possibly double hit lymphoma, primarily from various retrospective evidence and limited prospective studies of this. But regardless, generally a dose-intense approach is associated with a better outcome in patients with double hit lymphoma. And I think there is some difference of opinion whether that's necessary or not, but for the most part, most folks, at least in the US, would lean towards using our EPOC for patients with double hit lymphoma and large cell lymphoma. So these are the MYC involved, BCL6 involved, aggressive high-grade B-cell lymphomas. So in those settings, our EPOC would not be an unreasonable option. And then in the select situation, you can always modify your frontline chemotherapy. COP is another option, mini-CHOP for elderly patients, and GCVP. So there's so many options that you can use, the pregnant patient, patients with a compromised cardiac function, and so on. I generally feel that a lot of times when patients initially present, they may not have good performance status, they may have extensive systemic involvement of their disease, and organ function may be compromised. So in those cases, a lot of times just treating them with steroids can actually allow us to get the disease under control while you're getting your pathology confirmed and so on. And then subsequently, you can treat them more definitively with either option that you have access to. The other thing that I've used in my management of these patients, especially those which have a lot of disease up front, is giving them a short course of cyclophosphamide, so something like 200 for 3 days. And that allows me to debulk the disease, cool the patients down, give them a break, allow their organ function to recover before you commit them to definitive therapy. A lot of times I feel that if I start off with R-CHOP up front, sometimes the tumor lysis risk may be too high and may have more complications with that kind of an approach. So it all depends on the situation that you are dealt with, and then you have to modify and be smart about it. I think there are two things that I would say that there is pretty good consensus on, is that there is no role for maintenance outside of a clinical trial unless there's a pre-specified protocol, and there's no role for a consolidative autologous transplantation in first complete remission for patients with frontline large cell lymphoma if they go into a CR. So with that, I'll wrap up my frontline. Now, what about the limited stage disease? We've always tried to cut down on therapy with R-CHOP. R-CHOP has been around for a long time, and it's worked very well, and it's served us really well over the years. So for limited stage disease, radiation plus CHOP was able to allow us to cut down the time of treatment on CHOP, cut down the cycles of CHOP. And then with the advent of rituximab, the prognosis improved significantly, and obviously that became the standard of care. So time-limited R-CHOP versus extended duration R-CHOP has been compared specifically in the SWOG studies, and it shows that over time, with longer follow-up, there isn't really an improvement in outcomes with either arm, but you can definitely cut down on the chemotherapy by using an abridged form with radiation, although you can argue that then you may have systemic relapses. That's why Can you get rid of chemotherapy completely if you have a very truly stage 1 disease that you can cut out or radiate? Historically, the answer has been no. Even if you do have like an excisional biopsy and you completely remove the tumor, or if you feel that that can be definitively radiated if it's in one spot, even with that setting, even in that limited disease test setting, the recommendation would be to do systemic therapy so that you don't have systemic relapse, or the risk of systemic relapse would be lower. So that's kind of the reason why 3 to 4 cycles of R-CHOP, depending on how you schedule your scans and how you schedule your radiation, sometimes there's a delay, that should be considered a standard treatment at this point. There are other approaches for select patients with very low IPI. You can cut down to 4 of R-CHOP followed by 2 of R as in the flyer regimen. But anyway, for certain specific patient population, especially with patients with limited stage disease, it's not unreasonable to try to come up with ways to cut down on chemotherapy, and R-CHOP 3 to 4 followed by involved field radiation should be a fairly standard approach for those patients. Now, in select cases, like I said, you can probably eliminate involved field radiation, but those would be very limited cases with very low IPI disease. All right, so what about the relapse setting? Like I said, there is a dedicated talk on that, so I won't belabor this too much, but essentially when I'm looking at a patient with relapse disease, I am looking for patients who have the option of going to transplant with regards to their fitness, age, insurance issues, coverage, whatever you have, and also the patients who had early relapse versus late relapse. So all of these factors are important for me to consider right at the first time when I see a patient with relapsed large cell lymphoma or refractory large cell lymphoma, and that tells me which path I want to go on. And because if my intent is still curative with a transplant or CAR T, then I might use polatuzumab with rice, or I might use Pola-R and follow them up with CAR T to take them to harvest their cells and take them to CAR T. But if I'm going for a transplant-based approach, polatuzumab with rice is served as well. Now, with evolving treatment now, how would repeat polatuzumab work if they've already had polatuzumab R-CHP? And, you know, there is some debate about how we will manage that situation. But regardless, we will have whatever chemotherapy that you're comfortable with, ICE or DHAP or ESHAP or GDP or GEMOX, whatever you use, the point is that that would be an approach that you'll have to decide based on what your intent is. Are you taking the patient to CAR T, or are you taking the patient to an auto transplant? And because some of the patients who do have chemosensitive disease, even in the early or late setting, those patients can be very nicely salvaged with auto transplant. So in my mind, for chemosensitive disease, auto transplant still has room. Now, if I'm not going with that approach, then I'm looking at more of a control approach. How can I control the disease for as long as possible? And in that case, then I'm looking at bispecific antibodies. I'm looking at treatments with relatively lower toxicity, something like lenalidomide with tafasitamab, and so on. So I'm not necessarily then going with high-dose intense chemotherapy, because the mindset, the approach is to control the disease rather than cure the disease. And why do we use rice and Pola rice? And because the responses and the ability to salvage patients related to that has been very impressive with this therapy, especially in patients who have not had prior polatuzumab. You're getting complete responses in 50 to 60% of patients, when almost everybody has some sort of response. So that was one of the reasons why Pola rice has been a fairly standard option for us. Pola BR is reasonable if the intent again is not curative, because harvesting of B cells for your CAR T and then transplant can be tricky with Pola BR. All right, frontline Burkitt lymphoma. What do we do? So what's the issue with Burkitt lymphoma? Fortunately, it's not very common, but luckily we are able to cure a lot of patients with Burkitt lymphoma. So a lot of these patients do well. What is the issue though? This is the problem: high early mortality. I remember seeing a poster a few years ago in Pakistan where 30% of, almost 35% of patients with Burkitt lymphoma in various hospitals across the country, had early mortality within the first month of presentation. And that is not just true for any specific part of the world. It's true across the board. Even in the US or in European countries, early mortality is an issue. Almost up to 30 to 40% of patients, especially if you're elderly, will die within the initial presentation, the first month or two of presentation of Burkitt lymphoma. So recognizing that time is of essence in Burkitt lymphoma, you cannot sit on it. You have to move. You have to come up with the diagnosis. Patient has to be managed aggressively, supported aggressively to get them through that first period, and then those patients do really well. So early diagnosis, risk stratification, aggressive management of tumor lysis, that's a big problem with Burkitt lymphoma. CNS prophylaxis is another one. And then use the Burkitt lymphoma IPI rather than the large cell lymphoma IPI. I think that's also an important point that I wanted to make, because that does impact our management for patients with Burkitt lymphoma. What do we use? We have historically used McGrath regimen. It's been around for 30 some years, with the modifications obviously along the way with rituximab addition. So our CODOX-M, our IVAC, based on the LY10 studies of multiple other studies, you can adopt. And the point here is that as you get older, the outcomes are worse. And then with 14-18 translocation, that was one of the things that was identified in this particular trial as one of the poor risk features for these patients. But generally, patients who have otherwise healthy, good organ function, younger patients tend to do well. And after the early drop-off, the vast majority of those patients, 70-ish%, should have long-term sustained remission and cures from their Burkitt lymphoma. CODOX-M is intense. It's short duration. It's very involved. But if you stick to it, then you will have a very good outcome, as has been shown by the Canadian experience, that patients who had minimal interruptions of their therapy actually had a better outcome. And obviously, if you're younger, you have a better outcome because you're able to tolerate treatment much better. Do we use hyper-CVAD and do you use other ALL-like regimen? The answer is no. We feel that that adds unnecessary toxicity, although there is obviously no randomized comparison there. So our standard approach, especially for young patients, is CODOX-M IVAC. What about EPOC? Not unreasonable. The EPOC versus CODOX study was stopped early, and we now have reported results of those. There was no significant improvement with the use of EPOC. If anything, it looks like it's a little bit on the lower side, but definitely not superior. It is better tolerated. Both of them appear to be equivalent in terms of long-term disease control. There was also a concern of CNS relapses with EPOC, but with the right CNS prophylaxis, that issue should not be a problem. Disease-specific survival appears to be fairly similar between CODOX and EPOC. So it's interchangeable. So for our young, fit person, 60, 65 or less, sometimes 60-year-olds are not in good shape, that person is something that I would be considering CODOX-M IVAC. And for the elderly, unfit or HIV-positive patients, we would lean towards our EPOC chemotherapy with CNS prophylaxis. Another problem with relapse Burkitt, what happens when that happens? Luckily, it's not very common. When it does happen, it's almost always bad news. So how do you control them? You decide whatever you want to do. You can do whatever chemotherapy that you're comfortable with. But the idea is that as soon as they get into CR, you have to consolidate them with some sort of a transplant. And the disease control is the key. Chemosensitivity is the key. You can argue that auto versus allo, there's always a debate, but this is old PBMT data, which really shows dismal outcome of patients with relapsed Burkitt's, and there really isn't any consensus. So clinical trials of transplant or CAR-T, there's a recent Chinese report of concurrent transplant CAR-T back-to-back may have been associated with a good outcome, but these are always difficult patients to manage. So our best chance of cure is up front, so use our best treatment up front, and that maximizes our curative potential. Obviously, you have to consider cost of care, accessibility, and long-term outcomes. But generally, fortunately, a lot of our patients now with large cell lymphoma and also with Burkitt lymphomas can have a long, sustained disease-free interval. So with that, I'll stop, and I look forward to a nice discussion. Thank you for your attention.
Our next speaker is Professor Sairah Ahmed, who is a professor in Department of Lymphoma, Myeloma, University of Texas, MD Anderson, USA. Over to Professor Sairah Ahmed.
Lymphoma and myeloma, as well as stem cell transplant and cellular therapy. And thank you so much for inviting me to speak about indolent lymphomas today. These are my research disclosures. Today we're going to be discussing 3 specific topics. Sequencing in terms of treatment for follicular lymphoma, marginal zone lymphoma, and hairy cell leukemia. How do we choose frontline therapy? And then what are the treatment options in the relapse setting? This is a very busy slide, but really what it denotes is when you have small B cells, there could be multiple diagnoses. And the way in which we decide how we are going to give a histologic confirmation is based on the cell markers. So follicular lymphoma is generally CD5 negative, CD10 positive, marginal zone is CD5 negative, CD10 negative, and hairy cell leukemia is CD10 negative, but then conversely also is CD103 positive and CD25 positive, and then can certainly be CD123 positive as well. When we are kind of diagnosing these, and by we I mean our very smart hematopathology colleagues, we largely depend on their expertise to help us understand the differences. And oftentimes there can be overlap, so it's not such a clean diagnosis that you're always going to know exactly the histology with the amount of tissue that you receive. Having a good tissue sample is absolutely necessary in order for the diagnoses for indolent lymphoma. Follicular lymphoma is considered an indolent disease. The life expectancy for most patients are that about 90% of them will have a 5-year survival after diagnosis. More common in older adults. It's very rare in young adults, and the treatment is based primarily on symptoms rather than stage or biology. The actions of the disease, however, can also potentially impact prognosis. So, for example, if disease relapses early, within 24 months, that is a negative prognostic indication. And there's limited data in terms of the optimal sequencing. At this time, we generally kind of have created recommendations, but there is no clear standard in terms of how we sequence these drugs. And there's always a lifelong risk for transformation, about 10% over a patient's lifetime, that an indolent follicular lymphoma may actually transform into something that's much more aggressive. In terms of incidence, for B-cell lymphomas, again, the vast majority of B-cell lymphomas are aggressive diffuse large B-cell lymphoma. Follicular lymphoma is about 12% of the population, with marginal zone being 7%. And hairy cell leukemia, in fact, only 2% of all lymphoid malignancies. Prognostic factors such as the FLIPI, which is a combination of a score based on age, stage, hemoglobin, LDH, and nodal sites, have differentiated patients into low or intermediate or high risk, and do help prognosticate in terms of outcomes. There has been an update in terms of FLIPI with the addition of a beta-2 microglobulin. However, more recently, there have been other factors that have been added in terms of gene mutations that have allowed us to discriminate a little bit better in terms of prognostic impact of the FLIPI, which is more clinical factors, as well as the molecular permutations that impact the prognosis of follicular lymphoma. There are a subset of patients who can potentially be observed without any treatment, and those are early stage disease that have no symptoms. And for a large number of patients, they may actually not require treatment. Now, again, this is mostly older data, but I think that this still holds true that we need to be careful in terms of when we start to treat patients. Early stage follicular lymphoma can actually be extremely radiosensitive. And for stage 1 disease, certainly radiation should be considered as the first option if it is in a site where the field will not cause significant side effects or complications. And even for stage 2 disease, if it's less than 3 centimeters, I would consider radiation for early stage follicular lymphoma. How do we determine low versus high tumor burden? really, if you have any of the GELF criteria, that is automatically considered high tumor burden, and they are listed here. This is a schematic of how to think about treatment for advanced stage treatment-naive follicular lymphoma. If there's not an indication for treatment, I generally would advocate active surveillance. For a number of patients, the anxiety associated with having a diagnosis of cancer without treating it is significant. And I think that there are a subpopulation of patients who don't meet GELF criteria who do benefit from rituximab monotherapy, more so because they're unable to kind of overcome the anxiety of waiting for, quote unquote, the other shoe to drop. I think in terms of high tumor burden follicular lymphoma, there are a number of trials that have been done. We can look at RCVV versus R-CHOP versus rituximab fludarabine based therapy. And clearly we can see that R-CHOP is probably better in terms of outcomes. Fludarabine-based regimens do have equivalent efficacy, but there is a significant risk for secondary malignancies. When we talk about bendamustine, Rituxan versus R-CHOP, probably we see less toxicity in terms of bendamustine Rituxan with fairly equivalent outcomes. And then the BRIGHT trial was BR versus R-CHOP versus RCVP. And there was a similar overall response and PFS for all of the regimens with slightly different toxicity. There are other regimens, for example, the obinutuzumab chemotherapy versus rituximab chemotherapy trial in terms of the gallium trial, which demonstrated that actually obinutuzumab plus chemotherapy had improved PFS, 63% versus 55%. But again, these patients all did fairly well. For certain patients, I think rituximab plus lenalidomide is a very good option, and in fact, it's quite well tolerated with equivalent outcomes to our chemotherapy. And so we are kind of having the luxury of multiple choices in terms of how do we treat patients with treatment-naive follicular lymphoma. I generally choose bendamustine Rituxan as my first choice for patients who have fairly good performance status without significant comorbidities. It is a time-limited treatment, and overall the toxicity profile is better than R-CHOP. And you don't have to worry about the anthracycline and concomitant cardiotoxicity. I tend to use Revlimid and Rituxan for my more frail patients. The other reason that I choose bendamustine Rituxan over R-squared is overall time on therapy. BR is a time-limited therapy, and once patients are done with chemotherapy, then they are able to move on, whereas R-squared does have a very long tail. In terms of maintenance therapy, I generally do not advocate for maintenance except for specific cases. We know based on the PRIMA trial that rituximab maintenance is superior. However, when we look at the rituximab containing first-line therapies, we probably aren't getting a whole lot more bang for our buck by adding in maintenance. So in terms of who do I choose maintenance therapy for, it's those patients who have a partial response. I do not use maintenance in patients who have attained a complete response. So in summary, for frontline follicular lymphoma, patients can expect a very long survival. And so we want to minimize toxicity while maximizing their treatment regimens. Patients relapsing within 2 years of initial chemotherapy have an inferior survival. The active surveillance observation method is appropriate in low tumor burden and asymptomatic patients. And some patients with stage 1 disease can be cured with involved field radiation. Rituximab plus bendamustine or rituximab plus CHOP generally are time-limited therapies and overall well tolerated, but rituximab plus lenalidomide is also a good first-line option. In the relapse setting, we know that the more lines of therapy that a patient requires, the worse the prognosis. And in fact, that patients are in the relapse setting dying of their disease. And the more lines of therapy they receive, the less efficacious those treatments are. I think one of the caveats to the LymphoCare study was that this was at a time period where CAR T-cell therapy was not readily available for patients with follicular lymphoma, and so these curves may certainly change for those patients who are able to access CAR T-cell therapy. I'm not going to kind of delineate all of the data in the relapse refractory setting. However, there are multiple regimens that are available. And in fact, if a patient has received bendamustine or Rituxan, you could potentially go on to a CHOP-like regimen in the second-line setting. Oftentimes, these patients are older and more frail. And so my go-to in the second-line setting is generally a rituximab lenalidomide-based therapy or potentially obinutuzumab lenalidomide. Tazemetostat can potentially be an option for EZH2 mutated patients, and CAR T-cell therapy has the opportunity to potentially have a functional cure for a subset of patients. However, the vast majority of patients, while having a fairly long response, will ultimately have disease relapse even after CAR T-cell therapy. In terms of newer approvals, the T-cell engagers are very exciting. We don't know exactly yet what the long-term survival is going to be with these drugs and how they'll change the landscape. And I think that the combinations of T-cell engagers plus other agents is just starting. Zanubrutinib plus obinutuzumab is a good option as well. And for a subset of patients, high-dose therapy plus autologous stem cell transplant can still give a good disease-free time period. And for a small subset of patients, allogeneic transplant can be a curative intent treatment. Although I would say that for every patient, I would consider CAR T-cell therapy before an allogeneic transplant today with a diagnosis of follicular lymphoma. We're going to move on to marginal zone lymphoma. There are three distinct subtypes. There is nodal marginal zone. There is gastric versus non-gastric extranodal marginal zone. And then there's splenic marginal zone. They do have certain shared features, including clonal expansion of centrocyte-like and monocytoid-like B cell with a marginal zone and intrafollicular expansion. Their immunophenotype is CD20 positive, CD5, CD10 negative, and often cyclin D1 negative as well. There are infections that are often associated with marginal zone lymphoma. And so certainly I think that treating those infections first is one of the primary treatment modalities when there's an extranodal marginal zone lymphoma. And then low-dose radiation can often be very efficacious in this particular disease. And in fact, we very much involve our radiation oncologists when we're treating marginal zone lymphoma. The current landscape for marginal zone lymphoma is often frontline therapy with chemoimmunotherapy, including bendamustine plus rituximab, R-CHOP, RCVP, as well as Rituxan monotherapy. And part of the decision in terms of chemoimmunotherapy versus immunotherapy alone is the patient's performance status, comorbidity status, as well as overall tumor volume. Certainly patients can still be treated with lenalidomide and rituximab. I have never used chlorambucil plus rituximab, even though it is often on the guidelines. And I think marginal zone lymphoma can also benefit from maintenance therapy with rituximab. Again, the risk versus benefit ratio in terms of infection and the time and financial toxicity associated with receiving a treatment for up to 2 years as well. In the second line option, you can kind of cycle through all of these same options that you had in the frontline setting. PI3 kinase inhibitors have been withdrawn from the market in the United States as a treatment for marginal zone lymphoma. And there are BTK inhibitors that have been shown to be quite active. After 2 or more lines of therapy, axicabtagene ciloleucel or Yescarta has been tested, and again, for a subset of patients, likely is curative in intent treatment. However, the majority of patients will have relapse after CAR T-cell therapy for marginal zone lymphoma. I think when we start to talk about why CAR T-cell therapy should be utilized in indolent lymphomas, oftentimes after frontline therapy, the amount of time that patients are on treatment for indolent lymphomas is quite lengthy. And so if CAR T-cell therapy can potentially give patients a prolonged duration of time off of therapy, I think that is beneficial both in terms of financial toxicity as well as overall quality of life. Appropriately, there are still patients that you can just watch and wait if they have low tumor burden and are otherwise asymptomatic. For splenic marginal zone, we use rituximab as frontline therapy. However, there's a subset of patients where splenectomy may also be a very good treatment. And my first choice for nodal marginal zone is again bendamustine plus rituximab. For BTK inhibitors, zanubrutinib has better outcomes than ibrutinib. And so if I have a choice, I generally would use zanubrutinib. And then the last topic that we're going to kind of talk about for a little while is hairy cell leukemia. So this was first reported in 1958. The BRAF inhibition causes this particular visual effect, which looks like hair. It's quite rare, with only 2% of all leukemias and lymphoid disease being hairy cell leukemia. And in fact, the estimated annual cases in the United States for classical hairy cell is about 1,000 cases, and for the variant is about 800. It's often a very indolent disease and is considered to be incurable. However, patients can live more than 25 years after initial diagnosis. There is kind of some different variants that we see, and they have phenotypically a different disease state. So you have kind of the BRAF mutation associated hairy cell leukemia, which is about 60 to 90% of all patients with mild splenomegaly, usually do not have lymphadenopathy, and may have a presentation with significant cytopenias. This is CD25 positive, CD103 positive, CD123 positive, and TP53 negative. And then you have the IGHV4 variant, which is quite rare, 2 to 5%, with severe splenomegaly, often lymphadenopathy and cytopenias. It does not have the BRAF mutation. Again, it is CD25 positive, and it may or may not have TP53 mutations. And then you have the hairy cell V variant, which again demonstrates splenomegaly, lymphadenopathy, but often can have normal blood counts. And they are interestingly CD25 negative, and often 30 to 40% may be TP53 positive. And then this would be just to kind of differentiate between splenic marginal zone, which is CD25 negative, CD103 negative, and could be CD123 positive negative, but is definitely BRAF negative. So what are the indications to treat hairy cell leukemia? So not everybody needs treatment at the time of diagnosis. An ANC less than 1,000, hemoglobin less than 11, platelet count less than 100,000, splenomegaly, lymphocytosis, significant lymphadenopathy, and or having frequent infections. These would all be indications to treat. And in fact, patients are often treated with purine analogs up front. Today, the most common frontline therapy is cladribine plus rituximab. Pentostatin is rarely used, and then potentially you could use vemurafenib plus an anti-CD20 monoclonal antibody. Cladribine plus rituximab, again, these numbers are quite small if you look at this clinical trial, but because of the overall incidence of hairy cell leukemia, But this analysis shows that it is extremely effective in terms of eliciting MRD negative status. And that's MRD negative in the bone marrow as well as in the peripheral blood. And this was a study that was done by Dr. Chahara from our institution when he was at the NIH. In terms of relapse disease, there is BRAF inhibition, and there's also MEK inhibitors that have been shown to have significant efficacy. So vemurafenib plus rituximab has a complete response rate of 87% with an MRD negative of 60%, and dabrafenib plus trametinib, which is a MEK inhibitor, has a CR rate of 66%. And again, and this is a 2-year PFS of 94% in relapsed hairy cell leukemia. So in conclusion, treatment of hairy cell leukemia has dramatically improved by purine analogs, and many patients can actually achieve a functional cure with survival comparable to the general population. Cladribine and rituximab is frontline therapy and fairly standard, and BRAF inhibitors can potentially be used in relapse. BTK inhibitors have also been tested in this area and potentially can be used beyond chemoimmunotherapy. There are patients who have high-risk disease, and there are potentially other treatment modalities that may need to be utilized for those patients. And as of current status, CAR T trials are ongoing. So I hope I have demonstrated that these indolent lymphomas can have very good overall prognoses, and in fact with treatment can potentially allow patients to live their normal life expectancy. However, there is still more work to be done for patients that have relapsed disease, as their survival is not equivalent to those patients who have kind of longer durations of response. Thank you so much for being with me during this brief talk. My email address is listed here. I would be happy to answer any questions, even offline. Thank you.
Thank you. Thank you, Professor Sairah. Now we're going to move to our last talk of the session, and then we'll be having a Q&A and panel discussion. So our next speaker is Professor Mehdi Hamadani. He is a professor of medicine and chief of hematological malignancies at Medical College of Wisconsin, USA. So Professor Mehdi Hamadani.
Hello, everyone. My name is Mehdi Hamadani. I'm a lymphoma and blood cancer doctor in Medical College of Wisconsin in USA. Kind thank you to this invite. I'm honored to speak at your event. I've been asked to talk about sequencing of therapies in patients with aggressive lymphomas. Aggressive lymphomas, particularly in the relapse refractory setting, in the recent years have gotten complicated. Gone are the days when the only curative modality for those patients in relapse setting used to be salvage chemoimmunotherapy followed by autologous stem cell transplant. In the relapse refractory setting, at least in the Western Hemisphere, we have several immunotherapies available, including naked antibodies and drug antibody conjugates, bispecifics, cellular immunotherapies, and the application of these treatments is dependent upon the timing of the relapse and, of course, with patients' demographics and fitness. To start the conversation about management of relapse refractory lymphoma patients, I'm going to use a real-world example of a patient of mine, 72-year-old gentleman, presented with an enlarging mass on his chest, shown in the PET CT. His family history was significant for myeloma in his brother. Medical comorbidities included gastroesophageal reflux disease, dyslipidemia, and atrial fibrillation. On laboratory evaluation, his LDH was mildly elevated. So the patient undergoes staging evaluation that you've already seen. Biopsy of the chest wall mass was consistent with non-GCB large B-cell lymphoma. FISH did not show any gene rearrangement for MEK or BCL2, as is uncommon in the non-GCB subtype. CSF analysis was negative. So patient was staged as stage 4 IPI score 4 large B-cell lymphoma. He started treatment with R-CHOP. You can make an argument that perhaps it should have been Pola R-CHP, which is fine. Patient had a slowly responsive disease in the community setting after 3 cycles of R-CHOP treatment and went on to receive a total of 6 cycles. At the end of his therapy, the patient's PET scan is shown here. This is clearly primary refractory disease, and a repeat biopsy confirmed the presence of refractory disease. So for these primary refractory patients, what would be the management option? I'm giving you a few options: salvage chemoimmunotherapy followed by transplant, polatuzumab and BR, Tefalen, CAR-T, or bispecific therapy. So historically, in these cases, we may have considered salvage chemoimmunotherapy, but as all of you know, these are the data from Parma trial that the response rates to salvage immunotherapy for these primary refractory or early relapsing aggressive lymphoma patients are low, and most of these patients do not benefit from this approach of chemoimmunotherapy and subsequent high-dose therapy and autologous stem cell transplant. This particular question was addressed with now 3 famous randomized trials, Zuma 7, Belinda, and Transform, that at the very heart were assessing outcomes of salvage chemoimmunotherapy followed by transplant versus CD19 CAR T-cell therapy in aggressive lymphoma patients with either primary refractory disease, like the case I shared with you, or relapse within 1 year of finishing chemoimmunotherapy. These are the top line results or the bottom lines from these 3 trials. On the right is the T-cell trial, which was a negative study, probably because of the potency of this CAR construct and maybe because of the turnaround time in manufacturing this CAR T-cell therapy. While on the left and in the center are the results from the Axi-cell and the Lysocell trials that showed a clear event-free survival benefit in favor of CD19-directed CAR T-cell therapies. And with the Axi-cell, we now know that there is a survival benefit in favor of CD19-directed CAR T-cell therapy. So in my opinion, in areas of the world with access to CAR T-cell therapy, if I see a patient like that, the clear management option in these patients is CAR T-cell therapy, if you could take these patients to this therapy approach. Now, continuing on with the same case, my patient received polatuzumab vedotin and Rituxan as a bridging treatment to CAR T-cell therapy, and then he went on to receive CD19-directed CAR T-cell therapy with Axi-cell. Unfortunately, a few months down the road, patient continues to feel unwell, and his day 90 PET scan is shown on the right. Clear refractory disease that was biopsy confirmed. At the time of confirmation of refractory disease, patient did not have any antigen loss. So for these patients with CAR T-cell therapy failure, the question for audience is what options you would think about. Would you go back to chemotherapy and autologous transplant, or would you gravitate to more novel options like ADCs, loncastuximab, or antibody IMiD combinations, or bispecific therapies? So CAR T-cell therapy is an important paradigm shifting treatment, but of course it doesn't benefit every single patient. Failure of CAR T-cell therapy is common, and these are the outcomes of patients who failed CAR T-cell therapies. This is data generated by my prior fellow, Joanna Zirko, that shows that the median survival of patients failing CAR T-cell therapy, even if they are offered salvage therapies, is about a year. So for these patients, we really have to think outside the box. Conventional antibodies, antibody drug conjugates may not provide durable disease control. So for this specific scenario, we really have to start thinking about bispecific treatment, and there are several bispecific antibodies either close to approval or already approved for patients with both indolent as well as aggressive lymphomas. Some of these bispecifics are administered intravenously. Epcoritamab is administered subcutaneously. Their administration schedules are different, as I'm showing in the summary table, and their duration of administration is also different. Glofitamab and mosunetuzumab are fixed duration therapies, while epcoritamab is continued until treatment failure or intolerance. So how do bispecifics work in patients with CAR T failure? I'll start with epcoritamab, which is a CD20-directed bispecific antibody. It binds to lymphoma cells using CD20 and T cells using the CD3 receptor, creating an immune synapse, activating the T cells, leading to T cell mediated cytotoxicity. So these are the pivotal data from the NHL-1 EPCOR study in third-line setting or beyond in patients with aggressive lymphoma. So if you look at the table on the left, 157 patients enrolled, overall impressive activity, response rates of 60% plus, 39% of the patients achieved a complete remission. And if you pay attention to the second last block on the left, is the efficacy of epcoritamab in patients with CAR T-cell failure. So the efficacy ranges from 54% to 46%, depending on if you're relapsing after CAR T-cell therapy or if you're refractory to CAR T-cell therapy like the patient I showed you. Even in patients with CAR refractory disease, the complete remission rate is a respectable 28%. At the bottom right are the rates of CRS and ICANS, but we will come back to those toxicity data later. These are the long-term outcomes of epcoritamab treatment among patients who achieved a complete response shown at the ASCO meetings in 2024. And among patients achieving a complete response, 2/3 of the patients are in ongoing complete responses 2 years down the road. The second relevant bispecific is glofitamab. Glofitamab is administered intravenously using a fixed duration therapy, and it has 2 binding domains for CD20 on the lymphoma cells. These are the bottom line data from the phase 2 pivotal glofitamab study that enrolled 155 patients, impressive response rates of 51% and nearly 40% of patients achieving a complete remission. Now, how does glofitamab perform in patients with CAR failures? So I'll draw your attention to the table on the left. The very right column are the data on patients with prior CAR T-cell therapy. Glofitamab is active in patients with CAR T-cell therapy. Overall response rates 50%, complete response rates 37%. And among the patients achieving a complete response, their 24 months duration of complete response was 33%. So in very challenging to treat patients, these are really provocative and impressive data. Now, glofitamab, since it is a fixed duration therapy, it gives you an idea of looking at the outcomes of patients who stop therapy in complete remission. And in such patients, if you look at from therapy stop onwards, majority of these patients remain progression-free and alive 18 months or so down the road. Now, unlike CAR T-cell therapy, bispecifics have a more favorable toxicity signal. CRS rates and severe CRS is way more uncommon, and severe neurotoxicity is almost unheard of. So bispecifics are available off the shelf in areas where access to CAR T-cell is limited. Bispecific therapies are going to be game changers. They cause cytopenias, but more manageable than cytopenias of CAR T-cell therapies. If you start to use them, please learn and develop algorithms to prevent infections, particularly viral and PGP related infections, monitor their immunoglobulin levels, and the CRS and ICANS does happen, but is absolutely more uncommon. So for this particular case, CAR failure, I would gravitate towards bispecific therapy in centers who have access to those therapies. In my last case, I'm going to talk about a young patient saw several years ago in my clinic. He presented with a large mediastinal mass, underwent a transbronchial biopsy that showed large B-cell lymphoma without any MYC gene rearrangement. He had widespread bony disease, stage 4 at the time of diagnosis, treated with ARCHA, which was a standard of care at the time of his presentation, and enjoyed a complete remission lasting more than a year. He relapsed, underwent salvage therapy, responded with a CR, but unfortunately, we were not able to collect his stem cells for transplant. And immediately after stem cell collection failure, the patient unfortunately had progressive disease, and the scans are shown here. So this patient again received bridging therapy with polatuzumab and underwent an experimental CAR T-cell therapy that we generate and manufacture inside our institution. It's a CD19-20 directed dual CAR T-cell therapy that my colleague Nirav Shah has been leading. The patient achieved a complete remission on the trial, but at 6 months mark post-CAR, I'm showing you his scan. So he undergoes a repeat biopsy. And that biopsy showed the patient had lost CD20, but had continued expression of CD19. Now, CD20 loss by our detectable assays doesn't automatically mean that CD20 is truly lost, but for the sake of discussion, let's assume that this patient has actually lost CD20 expression. So how would you approach this gentleman? Would you give him Pola-BR? I wouldn't, because I knew that with bridging polatuzumab, he was not responding to Pola. But how about off-the-shelf ADC like loncastuximab tesirine or tafalen combination? Would you still use CD20-directed bispecific therapies? So I will talk about options that are directed against CD19 here. So the first option is tafasitamab lenalidomide combination. Tafasitamab, as you know, is a CD19-directed naked antibody which is combined with lenalidomide. And the reason for the combination is that lenalidomide augments anti-tumor responses by augmenting and stimulating NK cell and also augmenting tafasitamab's activity. So tafasitamab lenalidomide combination was approved because of the results of the L-MIND study. The L-MIND study enrolled large B-cell lymphoma patients in second or subsequent lines. However, these patients were predominantly second-line patients, and certain high-risk patients were excluded from tafalen study. Tafalen study didn't allow double-hit patients, didn't allow primary refractory patients, and of course, there were no CAR failures on the tafalen study. But with these limitations in mind, you can see the response rates with this agent are impressive, 57% with 40% of patients achieving a complete response. And the main toxicity of this regimen is cytopenias and len-related cutaneous toxicity. Most drugs in real world work less efficiently than the clinical trial population. So if you look at tafalen's activity in real world, particularly in patients with CAR failure, shown in the table on the bottom right, patients who are refractory to CAR T-cell therapy, tafalen's activity is below 10%. But if you relapse 6 months or later after CAR T-cell therapy, then a third of patients may respond to this treatment. The second relevant CD19-directed drug option is a drug called loncastuximab tesirine. It's a CD19-directed antibody drug conjugate. given every 3 weeks as an intravenous IV infusion. This drug got FDA approval based on the Lotus-2 trial that our group was heavily involved in. So tafalen as a single agent has activity of about 50%, with a quarter of patients achieving a complete response. And if you achieve a complete response, these responses are durable. The median duration of complete response has still not been achieved. And among the complete responding patients, a third of those patients off therapy were still in complete response 2 years down the road. These are the duration of response curves showing that if you achieve a complete response, and these are 24% of the patients who would do that, the complete remissions are long lasting. Does Lonca work as well in real world? Potentially, yes. These are the real world data that are coming out in Hematologica fairly soon, led by Emily Ayers and University of Virginia. So I will draw your attention to the table on the left. This real world study looked at Lonca's activity in patients with CAR failures. So about a third of patients responded to Lonca. So just like tafasitamab, Lonca also has modest activity in patients with CAR T-cell failure. So the patient that I showed you that relapsed after experimental CAR T-cell therapy with CD20 loss is tafalen or Lonca combination or Lonca reasonable options? I think yes, if you don't have access to clinical trials. I would personally use Lonca before I would use tafalen, but would also argue and accept the inverse combination as well. Option E is not the correct option. Allogeneic transplant is not an option for patients with active disease, but in young fit patients who have failed CAR T-cell therapy and happen to achieve a complete remission with subsequent treatments, we do consider allo transplant on case-by-case basis. So in conclusion, in the last few years, we have witnessed a proliferation in options of patients with relapse refractory aggressive lymphomas. For early relapsing patients or patients who are not transplant candidates, CAR T-cell therapy is standard now, but CAR failure is common, and managing these patients is an area of unmet need. For CAR failure, bispecifics is the way to go off trial, and I would even argue that in areas that have limited access to CAR T-cell therapy, start investing in getting access to bispecific therapies. Bispecific therapies, I haven't shown you the data, but bispecifics in combination with salvage chemoimmunotherapies have very, very high response rates, and it may give you access to transplant consolidations down the road if you do not have access to cellular immunotherapies. So I hope I kept to time. I'm so sorry that I may not be able to join your live Q&A discussion because of family commitments, but I'm grateful for your invite, and thank you so much.
Thank you, Professor Hamadani, for an excellent talk on a difficult topic. So now we've got a house open for questions and answers and a panel discussion.
Can you hear me?
Yeah, we can hear you.
So anybody from the lymphoma panel? One question I have is, if somebody with an aggressive lymphoma relapses within 1 year in this part of the world where CAR is not available, and you give these patients a salvage treatment and they have a chemosensitive disease, what would you recommend?
So I'm going to ask Professor Hamadani and Dr. Farrukh to answer that, please. Professor Hamadani first, please.
Assalamu alaikum, everyone. Hopefully you can hear me. I'm in sort of a noisy environment. So it's a very practical question for, I think, areas of the world where access to CAR T-cell therapy is limited. And I would even make an argument that even in practices like ours, where you have access to CAR T-cell therapy, it is controversial, but we have no direct randomized data available that show that in patients who demonstrate chemosensitivity despite early failure, that auto transplant is better than CAR T cell therapy or the other way around. But we at least have good quality observational data. So our group at CIBMTR has published 2 studies, both led by Dr. Madhyar Shadman. So in our first study, we looked at patients who achieve a partial remission to salvage therapy, then retrospectively compared outcomes of CAR and autologous transplant. And I won't claim superiority of auto transplant in that setting, but I think the outcomes were fairly similar. And more recently, Dr. Shadman also looked at patients who achieve a complete remission. And then you compare CAR T cell therapy and autologous transplant. And again, you see a very decent signal with auto transplant patients. And also remember, before the advent of CAR T cell therapy, not every single patient who relapsed early died, right? We were able to salvage and cure some of those patients with transplant. But I would admit that if you have access to CAR T cell therapy, that is clearly the way to go. But the scenario that you present, I think it is still reasonable to consider transplant in that setting on a case-by-case basis.
Okay, thank you. So Professor Farrukh, similar question, please.
Yes, I agree. I think, in my opinion, especially after the CIBMTR reports, it's encouraging that CAR T cell is fine, obviously, no debate there. But for the select patient with chemosensitive disease, auto transplant can also be considered.
Okay, and I've got another question in the context of Burkitt's lymphoma. If you've got a patient who's relatively younger, maybe in his 50s, but we are concerned about arcodoxam RI toxicities, as it is pretty toxic regimen. Can we use dose-adjusted R-APOC in those patients as well?
Absolutely. I think, like we discussed in the presentation, EPOC with CNS prophylaxis should be a reasonable approach in those patients.
Okay. And do you think in future, as the bispecifics data is coming in, what do you think that in a relapsed refractory DLBCL, do you think that sequencing may be altered further in the context of CAR T versus bispecifics?
Completely agree with you, and I would love to hear what other panelists have to say. But we are participating in the upfront CAR T cell study, and also with Dr. Hamadani, we are participating in ADC in the frontline setting. And there are studies, and we have already done those studies, and they have been reported partly with frontline bispecifics in the follicular lymphoma space. So in every space, there are multiple ongoing efforts about using bispecifics, ADCs, CAR T cells in the frontline setting. Obviously, the patient populations vary, high risk versus low risk, histology, and so on. But that is the biggest question in the field, in my opinion, is do you do CAR first or do you do bispecifics first? And then what's the optimal option in the frontline setting? And I know from the Zuma 23 study that basically patients are undergoing CAR T cell after one cycle of R-CHOP therapy. So they get harvested right away. And rather than getting a second cycle or subsequent chemotherapy, they just get a CAR T at that point. So we'll see what the updated results. Hopefully by next year, we will have some preliminary results. And that would obviously can be potentially practice changing for select patients, at least initially, and possibly for all patients in the future. But I would love to know what other people think.
Okay, so we've got another question from the audience, please.
Can you hear me? Assalamu alaikum. I'm Dr. Mariam, consultant from FPMTC. I have a question from Dr. Jasmine. This is regarding two of my frail ladies with Sézary syndrome. So we have been struggling to have a durable response in these ladies. They were referred to us. We initially treated both of them with cyclophosphamide. We didn't get a reasonable response. We've switched them to gemcitabine. But I would like your opinion on how to best manage Sézary syndrome in frail elderly patients. Oh, thank you so much.
So, thank you. You can hear me, correct? So Sézary syndrome, so she has peripheral blood involvement?
Yes,
and
she
skin
has.
involvement? Can you tell me? Right. So Sézary syndrome and mycosis fungoides, you have to think of them as compartmental diseases. There's a blood compartment, there's a lymph node, and then the skin, obviously. And there are different agents that target these compartments differently. Now, chemotherapy is really not the best option for these patients. And I understand you may have limited availability of these rare, these targeted drugs that are approved for a Sézary syndrome. Do you happen to have mogamulizumab by any chance, or Campath?
We do have Campath, but we would be very cautious given the high infections rate associated with Campath in a 75-year-old.
Right, I understand that, but I'll tell you, gemcitabine and cyclophosphamide are not going to work either. So the options are very limited. I've tried oral etoposide sometimes, that can, or low-dose methotrexate. You can try that. But really, and Sézary syndrome, the blood component is very difficult to treat without, targeted therapies, or photopheresis is another option. I don't know if you may have that because you guys do transplant, right?
Yeah,
so you
we
may
do have
these,
photopheresis, but that's really costly. So,
if you can even give her a few of those sessions in combination with either interferon. So interferon ECP is a very good combination for Sézary syndrome. I would try to stay away from chemotherapy as much as possible. First of all, responses are very short-lived, even if you have them, especially in the blood component. So ECP interferon is one option. If you can't give her the ECP, at least try the interferon. How about any retinoids? Do you have any of those available?
we didn't give retinoids, did we? We did give her interferon. Initially, she didn't respond to them. She progressed on methotrexate, and then we switched her to gemcitabine. We don't have bexarotene. We checked for it around. We do have about Campath, because we really have been cautious and we haven't tried in any of those patients. If you do suggest, what would be the dosage and regimen for Campath in these patients?
It's the standard dose. I mean, if you're concerned about toxicity, you could probably give her the lower dose of 10 milligram. Just kind of give it to her 2 or 3 times a week and see how far you can get with that. I know there's a risk of infection, but you're going to have to continue the gems. Is she responding to gemcitabine?
She does have a stable response at the moment, like her erythroderma and exfoliation, that's settled for now. She's just received 2 doses. Both of them started concomitantly, and both of them have responded. Yeah. Like at least the erythroderma phase is static.
Yeah.
So
yeah, I mean, if she's responding and you want to continue, you'll have to continue for a really long time, and that itself is going to increase the risk of infections.
But the blood component hasn't touched the blood component.
Yeah. It's very rare that it'll touch it, so you can combine that with something.
No, we did just the monotherapy.
Yeah. Yeah. So sorry, there's not a lot of good options for these patients, unfortunately. Best you can do is just kind of symptomatic control.
Thank you.
Yeah, Jasmine, if I may interrupt,
sure.
I obviously have shared a bunch of these patients with you before.
Yes.
Yes. So in this setting, because we deal with this setting too on a regular basis, unfortunately, post MOGA, post ROMI, post everything, and so on. So I guess the big question that I'm debating with right now is what do you think about pralatrexate and duvelisib, and also what about the Pembro recent, option for these patients with really refractory disease?
Yes, very good question. So I think pralatrexate I use quite a bit in tumor stage disease. So again, I look at these different compartments. I say, what is the main compartment that needs treatment? And so pralatrexate and brentuximab are good for, including pembrolizumab, are really good for skin tumor-related, if the patient has tumor presentation. Brentuximab does not work for blood compartment. We know that the CD30 expression is poor on peripheral blood. You can't even. So it seems to be more effective in patients who have either nodal disease or have skin disease. There is a trial ongoing at Memorial with low-dose brentuximab, so you can prolong the timing of treatment, time on treatment rather, without developing neuropathy. You can do, in terms of immunotherapies, we have had a trial with durvalumab and Revlimid, which will be presented at ASH, where we have actually had very good responses. It's an IIT, so because it's a rare disease, we haven't been able to present it earlier, but it will be presented as an oral presentation at ASH. We actually have durable responses there. So that's actually very effective combination, both for, it has worked well for skin patch plaque and tumor stage disease and for some Sézary syndromes as well. There is data from Stanford using pembrolizumab in patients with, again, skin involvement and tumor stage disease with like a 47% response rate, and certainly works well. It's combined with, there's a couple of trials ongoing in combination with romidepsin, pembrolizumab and romidepsin, and pembrolizumab and even gemcitabine. Actually, I think that trial is going to be negative, but pembro gemcitabine combination. But definitely a role for checkpoint inhibitors. You have to worry a little bit about flare. Even with Revlimid, you have to worry a little bit about flare, and know that it's flaring rather than an actual disease that's worsening. But if you can sort of work through that with a little bit of steroid maybe, or then and get over that little hump, then you start to see responses. Yeah, these are difficult patients to treat, unfortunately.
Yeah. So I also want to discuss about a patient with follicular lymphoma, 50 years old male, which was stage 1B, cervical nodal mass that was 8 centimeter, and the patient had B symptoms. Now, considering that the Guelph criteria, the patient's nodal mass is 8 centimeter and he has B symptoms, but it's stage 1B and the Ki-67 is 40%. So do you prefer ISRT in this, or would you say chemotherapy should be given, considering that it's like high Ki-67 and also bulky disease?
So we'll start with Professor Hamdani. It's a question about follicular lymphoma, bulky, early stage B symptoms.
Okay.
May I ask a follow-up question? Is it still grade 1, grade 2, or?
It's grade 1B. Bone marrow is not involved.
Okay. So typically in my practice, although we say that even for limited stage disease, you do involve field radiation, I have just a personal practice bias that I often end up not doing any radiation on these patients. But a bulky patient in cervical area, you eventually end up radiating a lot of salivary tissue. I like chemo-free approaches in frontline settings, so I actually gravitate a lot towards R-square for frontline patients. It does work in patients with a lot of disease as well. Or my second favorite option is BR, as Dr. Ahmed was mentioning. So I'm not saying that going to radiation is not the right option. It is, of course, a reasonable option in optimally staged patients. But I would probably go in a bulky limited stage patient, I would probably go towards an immunotherapy-based option.
Okay, thank you. So I think we're going to conclude our session. So thanks a lot for the participants, speakers, and the panelists as well. So this was the last session. So I congratulate everybody